Hey everyone, so I have another video for you to help you on your trans surgery journey, your journey of figuring out who might be a good fit for you. Today I'm talking with Dr. Rachel Bluebond-Langner, who is a surgeon in New York at NYU, who's rapidly becoming another leader in gender confirmation surgery. So stay tuned for more.
How are you? Good to see you.
You too. Yeah, I'm doing pretty good. How are you doing?
Good. We're back operating, which is good.
I like to just start from the very top, like asking what brought you to plastic surgery? What brought you into that field in the first place?
I really enjoyed the creative aspects of plastic surgery, that there was form and function and there was an artistic component to it. You went all over the body. You took care of people in all stages of life, and that people were generally happy and better at the end of surgery. So I did all of my training in Baltimore. I was in Baltimore for 17 years. I did medical school and then residency in Baltimore. I left for 1 year and I did a craniofacial and microsurgery fellowship in Mexico City, and then came back and joined the faculty in Baltimore, Maryland. And at that point, my practice was part gender affirming surgery and part general reconstruction.
What specifically brought you to the field of like gender confirmation surgery?
So for me, gender affirming surgery was the embodiment of plastic surgery. It was the restoration of form and function. It used both aesthetic and functional techniques. You use microsurgery, tissue rearrangement, aesthetic surgery, craniofacial surgery. And most importantly, I found that these were the patients that were happiest, and where I was able to make the most significant and meaningful impact on their life. And that was when I decided that my practice would migrate from maybe 50% gender affirming surgery and 50% reconstructive surgery, so breast reconstruction, cancer reconstruction, to purely gender affirming surgery. And I was fortunate enough to be recruited to NYU 3 years ago. And it was a wonderful opportunity to start the gender affirming surgery program here, and is truly multidisciplinary. I have an amazing colleague, or amazing colleagues. It started with myself and Li Zhao, who's a urologist, and we would do the genital surgeries together, and slowly grew. My mentor and our department chair is a very well-trained and amazing surgeon who does craniofacial surgery and reconstruction and does facial feminization. I have a wonderful partner, Jamie Levine, who does microsurgery with me, the Phalloplasties. And so it was this great mix of people all doing, committed to the same patient population, and I think pushing the field forward.
Yeah, it sounds like your team's doing like a lot of really awesome things. It sounds like you're really like covering the gamut of a lot of different surgeries for the trans community.
I think we're able to, each of our specialties, we're able to offer, I think, high quality surgery, and all of us are very committed and enjoy working with trans and non-binary patients.
Yeah, because I had noticed that you said you started at NYU about 3 years ago, because I was looking through some of your research and I noticed that's when it seemed like a lot of things in the past like 3, 4, 5 years in the work you were doing like shifted a lot. But it looked like a lot of past research you were doing was kind of like very much applied to trans surgery, like surgery with I think surgical flaps and peritoneal type surgeries, because it seems like that's where a lot of the technology, so to speak, is going when it comes to vaginoplasties. At least that's what I'm hearing from a lot of people these days.
It's certainly an exciting field. I was in Baltimore for 17 years. And so when I left in 2017 and came to New York, it was a big change. My mentor throughout medical school and residency was the chair at NYU, and he was who brought me here. And that's where my early research was. So I spent 2 years in the lab with him, and he does facial transplantation and microsurgery and craniofacial surgery. And it was really the marriage of the two, craniofacial and microsurgery, that the lab was focused on. And my interest in gender affirming surgery began in residency, and my research, I think, reflects the change in my practice and my interests now. And my practice is dedicated to gender affirming surgery now.
That's wonderful, because we definitely need more and more people doing this kind of work. One thing that I like to ask about before I do any sort of like consultation is wondering, like, what specifically does the provider do to make spaces like specifically safe and inclusive for trans people? Because, you know, I can speak from my experience. I know many other people in the community that have had a lot of bad experiences in healthcare from providers who just, for lack of a better word, don't know what they're doing. So I'm wondering, like, what is it specifically you do to make like trans and non-binary patients feel safe, comfortable, taken care of?
So as I said, our practice is dedicated to gender affirming surgery, and we have an entire wing of the outpatient floor. So when you enter, it's actually mostly only trans and non-binary individuals in the waiting room. I think we have signage making sure that you're comfortable sharing your chosen name and the pronouns that you use. And we've spent a lot of time and effort training our staff, making sure that they understand how to create a safe space for patients that historically have been marginalized and discriminated against specifically in the healthcare system. And so before I even came, the institution made the commitment to doing significant training both in the outpatient and the inpatient setting. We have a nurse navigator and a nurse liaison on the inpatient and the outpatient side to ensure that there's cultural competency and sensitivity throughout the hospital, and we've done a lot of training. And then we make an effort to employ trans-identified individuals and have trans-identified individuals on our team. Our research is actually also focused on patient-reported outcomes and patient-centered research. So we feel that that's the next step in moving the field forward, understanding what patients really want and hearing them. And when we design and develop materials for patients, we've employed our old patients to help us with that, so that it is informed by their experience, not by our projections.
Unfortunately, not how it has really ever been. It's great to hear that you're doing that. Is there anything you have off the top of your head of like what patients are typically asking for that maybe hasn't been seen at a lot of practices in the past?
I'm not sure. I think that the connections that we're able to make, we really emphasize making connections of past patients to future patients. And so, for example, with vaginoplasty, we have a vaginoplasty class that patients can attend. And it's a 5-hour class. It's almost a full day commitment.
Wow.
You're able to see the experience from start to finish. So you meet all of us, including myself and Lee Zhao. Each of us speaks. You meet the physical therapist, like the person who will do the pelvic floor physical therapy after surgery. You see the inpatient nurse practitioner, the outpatient nurse practitioner. You see, and then I think the conclusion and really the highlight of the class is the patient panel who shares their experience pre and post vaginoplasty and their various stages of healing and various ages and races and sexual orientation. So I think it's a really nice mix and captures the diversity of the experience.
I love that. That sounds so helpful. It's like a consultation, but like so much more.
Yeah, we know that when you come for consultation, it's very overwhelming. You're nervous, you're anxious, you're hoping you're going to get a date, and it's really hard to listen to what we have to say. And you probably remember about 10% of what we say.
Yeah.
The first meet and greet is, I think, to organize things, and then we have an education visit. We have the vaginoplasty class. And then we have a pre-op where we make sure that everything is in order with regard to your labs and your medical clearance and your consents. And then we see you every week initially in the beginning, and we want to see you every year. So we try to stay in close touch with you, and you become a part of our lives, and hopefully we become a positive part of yours as well.
Like a constantly growing family.
Yeah. Yes. Yes.
So I wanted to like briefly go back to one thing we were talking about a couple of minutes ago, talking about like putting competency training throughout like all the staff. And I was wondering specifically like what sorts of things do you do to make sure like nursing staff or like hospital healthcare staff like are using the right names and pronouns before they even get to you or other doctors? Because I know I personally have encountered issues where like the doctor's great, but the people I go through to get there aren't as knowledgeable, especially if like my paperwork was like, this is how I identify, but my paperwork didn't match it.
Yeah, I think you point out something that we certainly are constantly aware of. We're in a big system. There are many, many touch points throughout the system. There's, of course, turnover and additions to the team. And we are very careful about trying to not limit people's access, but really make sure that the path that people take to get to us is prescribed, and that individuals are vetted prior to joining our team. So people at the call center, the first person that receives your call, there's a lot of training that goes into teaching them. And I think one of the best ways that we found to educate people or to have trans and non-binary individuals share their own experience of what it's like to be misgendered and how really dangerous, painful that can be. We found that to be one of, and so we have trans trainers come and educate everyone from the person who takes your phone call to the nurses who take care of you, to the people who deliver your food when you're in the hospital. We're fortunate enough to work with the residents. So we're at a teaching institution, and the residents take great pride in their ability to care for compassionately and competently for the entire trans community. I think we all are constantly monitoring, and if we do, people will be misgendered. And we encourage patients to come forward, and we take it very seriously. And we take that as an opportunity to educate the staff again. But I think it requires physicians to really be on their toes and looking out for it and policing it, and making sure that patients feel comfortable at every step of the way.
That's amazing. I imagine it can get pretty complicated working in such a big system, it's like a university hospital. Is that?
Yeah, it's a university hospital, but I think people are proud of the services that we offer. They're excited to be part of the team. And I think NYU also does a great job in really supporting the entire LGBT community and putting that as a priority.
And I had a question kind of related to like working within the NYU system, because a few other providers I've talked to all work in private practice, so I imagine there's some differences there. Like specifically, I was wondering like, how do you navigate things like doing this interview or sharing anything online? Because I imagine it's a lot more complicated working within a university system than kind of being off on your own.
Sure, we have a media department, and they vet everything that we participate in. So we shared before I did this interview, I shared with our media team your YouTube channel and what you were doing, and they gave the approval. They don't control what we say, but
Sure.
like to be involved. And of course, our web pages are perhaps not as, they don't have quite the same content. They're much more uniform across providers. So an internist will look similar to a surgeon. So there's a lot more uniformity. So yes, we don't have the same social media, the same before and after photos, because it's more uniform throughout the entire institution. But it is great to be, I think one of the really nice things about being in an academic institution is the collaboration, specialties. Again, my partnership with Lee Zhao in urology is invaluable. The opportunity to teach and work with residents every day to train the next generation of surgeons and to have them be competent and committed to gender affirming care so that we have more competent providers and physicians out there. And then obviously the opportunity to advance the field through research and data-driven exploration are the things that I love about being in academic medicine.
You know, kind of speaking on like advancing the field, I was wondering if you could tell me and whoever watches this a little about some of the more newer techniques that you are using in terms of gender confirmation surgery, whether it's vaginoplasty or other surgeries.
Right. So I think one of the things that's unique about our team is that it is a plastic surgeon and a urologist, and so you have the benefit of both specialties. For genital surgery, so for both transmasculine genital surgery and transfeminine genital surgery, we have used the robot. And for both of those surgeries, you're working in the pelvis, which is a deep, dark space with a lot of blood vessels and very precious organs like the bladder and the rectum, which if injured can be devastating. And the robot gives you better visualization during the dissection of the vaginal canal or the removal of the vaginal mucosa during vaginectomy. So we feel, for example, in vaginoplasty, I'm working on the outside doing a standard penile inversion vaginoplasty and reconstructing the vulva. And Dr. Zhao, my partner, is coming from above, dissecting the vaginal canal, and we're meeting in the middle. It's also allowed us to do peritoneal flaps for vaginoplasty, which deepen the vaginal canal. And I think there are a lot of myths about what peritoneal flaps can and can't do. There's a bit of hype for that. In our hands, it's a wonderful donor site that is hairless, doesn't require an additional incision, and it allows for additional depth. In our experience, while there is perhaps some secretion that's produced, it's not going to provide you the lubrication that's usually required for receptive intercourse. So when you have receptive intercourse, usually the place where you want the lubrication is at the entrance of the vagina, and this is deeper in the canal. In addition, your peritoneum does not secrete fluid in response to being sexually aroused. And so it's important that you sort of understand these differences and I think set your expectations that it's a wonderful donor tissue, but does have its limitations.
Great. So what would some of the like benefits of the peritoneal flap be over like just doing your standard penile inversion surgery?
I think that the additional depth, particularly in women who have limited natal tissue. There are women who have limited natal tissue from birth. There are others who have been on puberty blockers. So for a variety of reasons, this adds depth in a minimally morbid way.
What would the like average depth comparison be in your opinion?
So generally we're able to consistently, without fail, achieve 6 to 7 inches regardless of what your natal tissue is. And so not everyone needs a peritoneal flap, of course, But it's nice that in those where there's less scrotal tissue or less penile tissue, you have a easy, minimally morbid tissue available.
So you wouldn't necessarily do a peritoneal flap if you had a patient who had like enough penile or scrotal tissue to make like 6 or 7 inches of depth?
Correct.
So one of the next things I always wonder about is dilation, because that's a question that often comes up a lot for people I'm talking to or considering surgery. Like, what does dilation look like, especially like with newer surgeries, like, peritoneal surgery, kind of. So I was wondering if you could briefly walk through like what is your recommended dilation schedule?
I think that that dilation is the most challenging part of aftercare in vaginoplasty, and is a tremendous commitment on the part of the patient. It can be uncomfortable, but more importantly, we're asking you to do something 4 times a day for 15 minutes. Putting sunscreen on your face 4 times a day is difficult, let alone doing something where you need to be in a private space and laying down. It's really becomes your primary job. It's difficult, it disrupts your schedule. And I think it's important to counsel patients and also keep that in mind as a frustrating component of the recovery process. That said, dilation is the key to this operation. No matter what you line the vaginal canal with, be it skin from the shaft, scrotum, peritoneal tissue, even bowel, where you're making a connection between the penile skin and the bowel, there is the desire for the body to collapse that space and contract along the suture lines. And unfortunately, it's still very primitive, but dilation is the only means that we have to keep the vagina patent as the body heals and prevent it from closing that space off. Now, obviously, the schedule decreases as scar contraction changes over time. So the most critical period of scar contraction is in the first 6 weeks. And then in the second 6 weeks, the dilation schedule drops a bit. And then again, it'll drop again until the first year, where at that point, scarring has probably stabilized.
My understanding is kind of like after the surgery, especially those first few months, it's extra important to dilate, because is it kind of like the body sees that, for lack of a better way, as like a wound that it wants to heal?
Yes.
And that's kind of what it prompts it to close if you're not essentially forcing it to stay open?
Yes, exactly. The body wants to close and contract in. And so you're trying to stretch it, soften it, and keep it open.
How often would you say dilation would be needed once you get to like that first year afterwards? So now it's pretty intense for the first like 3 to 6 months, if not longer.
Yeah. And I think it's hard. We think that at about a year, in most people, scarring has stabilized. It's not 100%. And so I still think it's important that you continue to dilate at least once a week. We always say the more you do it, the better off you are. It's probably like, the more you stretch, the less likely you are to become stiff and unflexible. But it's also a huge time commitment. So people understandably need to back off. We also say there are some surgeons who will say, oh, well, if you're having receptive intercourse, you don't really need to dilate. And I think that may be true. My only caution is if the size of your partner changes, you might be in trouble. So the dilate is consistent, and you know that you're going to have a consistent size and depth.
Right, because the partner might not be the same size as the dilator.
Yes.
Yeah, and that's something I had just heard from somebody recently, and I was like, oh, I hadn't thought about that. That makes a lot of sense.
Or your next partner. You never know.
Yeah.
Life changes.
So as I'm sure you're well aware, this probably much more so than I am, that this is a very complex surgery, like a vaginoplasty. So there's always potential for complications. So I'm kind of wondering, like, what would the process look like if a patient contacted you saying that they did have a complication or that maybe they even needed a revision, what would that kind of look like?
So we certainly see people for revisions. And I think one easy way to sort out revisions or understand revisions are revisions of the vulva, so external revisions, and then revisions of the canal or internal revisions. Things that we see people for external revisions will be labial asymmetry, so maybe one labia majora is bigger than the other, or there'll be too many rugae or wrinkles in the labial skin. Some people will feel the labia majora are perhaps too plump or a bit deflated, and we can adjust the volume. The next thing that we see is lack of definition of the labia minora. And I think that that's one of the challenges of the operation that we work to improve, is maintaining the definition long-term of the labia minora. And we can certainly revise that. And then clitoral hooding, making sure that the clitoris is nicely hooded and protected, but still obviously accessible. And then sometimes we'll see around the urethral meatus, or the entrance to where urine comes out, we'll see excess tissue that's been left behind there that needs to be removed. Then we talk about internal revisions or canal revisions. The most common canal revision that we see is stenosis or shortening, so narrowing and shortening of the canal, which makes it impossible to insert a dilator and impossible to have receptive intercourse. And this can be for a variety of reasons. There may have been loss of the skin graft or technique where the canal wasn't dissected deeply enough in the first place, but then there are also patient components where dilation for whatever reason was very difficult and the patient wasn't able to dilate and then lost depth and width. So there's canal revision for depth. Occasionally, fortunately it's rare, but occasionally we do see fistulas, and a fistula is a communication with the vaginal canal between the bladder and the vaginal canal, or the rectum and the vaginal canal. So we can address those. They're obviously much more difficult to fix and sometimes require 2 surgeries. And then the last thing that we occasionally see is excess erectile tissue that was left behind, and women will describe engorgement of the vaginal canal during arousal, and that whatever is in the vaginal canal, be it the dilator or partner, will be pushed out, and we can address that as well. So those are the sort of the common things that we see.
Lots of things that can happen, but it seems like there's a way to approach all of it.
There is, yeah.
I just had a couple more questions.
Yeah.
I think you've given me so much wonderful content here, so thank you. I always want to ask about cost, because it is a very expensive surgery, especially if insurance coverage can't happen. So I'm kind of wondering, like, what are some of the things that you and I guess NYU more broadly does to work with patients to help get, surgeries covered with insurance, or help them make it more affordable if cost is still an issue with or without insurance?
So for vaginoplasty in particular, I think if that's what should we focus on vaginoplasty?
Yeah,
okay.
Let's do that.
So we do very few self-pay vaginoplasties. We work very hard with patients to have this covered by insurance. It should be covered by insurance. There are still patients who are denied gender affirming coverage, but we work with lawyers to either change the decision made by the insurance company or the employer. We work with patients to approach their human resources department, particularly if the company is self-insured, because then they can change what is covered on the insurance plan. And we do a lot of phone calls and letter writing to make sure that insurance companies uphold their obligation for coverage. So I would say that my practice is 99% insurance-based. We do accept both Medicare and Medicaid, as well as commercial insurance. And so we're mindful of making sure that we are accessible regardless of your income status.
Wonderful to hear that almost everyone does get covered. I imagine it's quite a bit of work on the back end sometimes.
We have an amazing staff that is dedicated and fierce and really are committed to getting things covered for the patients. We believe that this is our patients' right to have surgery and to have it covered. It's medically necessary, it's life-saving, and definitely life-changing in a very positive way for everyone that has it.
Yeah, and I think I saw that part of what you do is also like craniofacial surgery, like facial feminization surgery.
So I was trained, I actually did my fellowship in Mexico City. My mentor is trained in craniofacial surgery and microsurgery, and I did a fellowship mostly in microsurgery and a bit in craniofacial surgery. He now does so Eduardo Rodriguez, my mentor, does all of the facial feminization now for our team. But he does, he's done 3 face transplants, and his background and passion is actually in facial trauma and secondary reconstruction, and has an amazing aesthetic eye. So I think produces fantastic and, most importantly, safe results.
I couldn't even imagine what would go into something like a face transplant. What does insurance coverage look like for something like facial feminization surgery? I know I've heard much more mixed things on that compared to like vaginoplasty.
Unfortunately, facial feminization and breast augmentation, I would say, are the 2 hardest surgeries to get covered. We're fortunate enough to be in New York, where Medicaid does cover facial feminization, and many private insurers have followed suit. And again, many companies have made it their commitment to have comprehensive care for trans and non-binary individuals, and that includes appropriate insurance coverage. It is an exclusion in more plans than, for example, vaginoplasty, but we do see more and more plans covering facial feminization.
Yeah, over the past couple of years, I've started to hear people getting it covered, and I was like, I didn't know that was even a possibility. So it's great to hear that it's moving somewhat slowly, but still in the right direction. So, kind of my last big question. We've talked a lot about kind of cool new things currently happening in the field with some of the technology and some of the surgeries that you and your team are doing. So I'm curious as to where do you see trans surgery going in the near future, maybe in the next 5 to 10 years? What do you think is the next big thing?
I think the first step is to have, again, patient-informed and patient-centered research and outcomes, so that we really understand what the pitfalls are of the surgery, not what we as surgeons think are the pitfalls, but really what patients are most frustrated by, or most pleased by, what patients want. And I think still the things that we as surgeons would love to work towards, I think the challenges remain reconstruction of the urethra in phalloplasty, and as you said, a vaginal canal that is lined with stretchy secretory mucosa that does not require dilation. So I think those are the 2 areas where tissue engineering can go. But I think it's important that all of our research be informed by our patients and not just by what surgeons think. Right.
So that way it's y'all are doing what people in the community want rather than doing what you think they might want. Great to hear that. That's kind of a trend we're seeing in psychology too in the past 5 to 10 years, is where more and more is much more informed by the community rather than the other way around, which is great to hear. That's like getting stuff that we actually know we want or need rather than what people with power are assuming we need, which is a really important shift. So kind of just my wrap-up question is, for anyone who may be looking for any sort of top or bottom surgery with you and your team, like how might they schedule a consultation? And if you had any closing words as to, I guess, your sales pitch for your work and your team, what would you tell people like why maybe people should go see you?
So you can call 646-501-4449, and you will be connected first to the call center, who will take your information and then schedule you for a consultation, and you'll then receive a call from our new nurse navigator to help you get everything organized in anticipation of your consultation. I think that here at NYU, we are a multidisciplinary team committed to performing safe, state-of-the-art, and compassionate gender-affirming care. It's truly our honor and our privilege to be a part of your journey. We think that this is a life-changing and a life-saving operation, and we are always humbled to be a small part of that positive change in someone's life.
Thank you so much for taking the time to do this.
My pleasure. Thanks for reaching out and for having me on this. This is great. Oh, you might need, see, I should have had pose, Electra is looking
I love that. That's wonderful.
She sits looking over us. So, yes. All right. Well, thank you so much, Chloe. It was wonderful to see you, and be in touch if you have other stuff. We're happy to join again on a different topic or have our team.
Yeah, that'd be awesome.
Yeah.
So again, thank you so much to Dr. Bluebond-Langner for taking the time to do this amazing interview. I hope this was very informative for all of you out there watching. I'd love to hear your reactions down in the comments below, any experiences that you've had with her either through consultation or actually having surgeries with her. I'd love to hear those. And as always, Tipsy and I love you all and hope you are staying as safe and healthy as you can during these tough times. If you have not done so already, please be sure to give this a thumbs up and hit that subscribe button and notification bell. Bye for now.